To those of you who are just joining the stream, we're counting down in less than 4 minutes. We'll be joining Bill Moss and Alvira Hasan, we'll be discussing community-based serosurveys and exactly how to conduct them. So stay with us. We'll be there. Let me check the countdown in 3 minutes and 20 seconds. See you soon. If this is the first episode that you are joining, this is part 2 of a 4-part series, so I strongly encourage you to go and check out part 1. Part 2 today will make more sense. You can find it if you're watching us on LinkedIn. Just look on the Geneva Learning Foundation's LinkedIn page, and you'll find all 2 parts today, and then parts 3 and 4 tomorrow and Friday. If you're on Facebook, look on our Facebook page, Digital Scholar, and you'll find it. You'll find part 1 there. If you're on Twitter or YouTube, the same applies. Just find our page, and happy to welcome one of our most regular scholars and supporters, Dr. Tanushree Mandal, connecting from West Bengal, India. A prolific commenter, always with good questions and comments. So Tanushree, thank you for joining us, and look forward to reading and sharing your comments and questions during this session. See you in 1 minute and 30 seconds. Here we go. Warm welcome to you from Geneva, Switzerland. I'm Reda Sadki, and this is part 2 of a 4-part mini-series we're doing with the International Vaccine Access Center. In the room with me, to my right, is Bill Moss. He's the director of the International Vaccine Access Center. Welcome back, Bill, for part 2 of this series. The International Vaccine Center. Can you give us a recap? What is it for those of you who missed part 1?
Yeah, so what we're doing here is that the International Vaccine Access Center is engaged in conducting serosurveys, largely for measles and rubella in Zambia and India, and we've learned a lot, and we want to share some of our experience and findings. We know many serosurveys are being done for SARS coronavirus 2, so that's the purpose of this these mini series.
Great, thank you, Bill. And today we're introducing a new character to the cast of this mini-series, Alvira Hasan. Kindly introduce yourself. Where do you work? What do you do? And when was the first time you heard the word serosurvey?
Thanks, Rita. My name is Alvira Hasan, and I work as the India Research Program Coordinator at IVAC. I'm based in New Delhi, and I've been working with Bill and his team at IVAC on measles and rubella serosurveys, primarily focused in India. I first heard of the word serosurvey about 3 years ago when I was a student at the School of Public Health, probably from Bill, and I was very interested in infectious diseases and surveillance. So since then, I haven't looked back. Thank you.
All right. So we are live streaming this series to LinkedIn. So if you're watching us on LinkedIn, let us know you're there. Leave a comment. We can see, and we'll be sharing your comments. Let us know what city and country you're connecting from, and if you have experience in serosurveys. If you're watching on YouTube, the same. You can leave us comments. We'll also see them and be able to share them with Bill and Alvira. Twitter is on Digital Scholar X. You can find the stream there. On Facebook, it's Digital Scholar is the page of the Geneva Learning Foundation. Now, before we go any further, I want to tell you a little bit about what we've been up to. This is a very busy week at the Geneva Learning Foundation, and specifically the COVID-19 Peer Hub. So this morning we had a workshop for the first time working with Dr. Anne Lindstrom from the World Health Organization headquarters, looking at what it means for immunization staff working in countries to be getting ready for the introduction of COVID-19 vaccine. And there was a workshop we did not think we would be able to do in 2020. So that was quite an exciting moment. You can find the recording right below this workshop. If you scroll down, you'll find the recording and still be able to leave your comments and questions. Tomorrow, we're connecting with Professor Heidi Larson. She'll be joining us here again on our page, on the page of the Geneva Learning Foundation. You'll be able to find the live stream, comment, ask questions, participate to discuss this critical issue of what makes people have confidence that a vaccine works, that it is safe, that it's effective. That's what we'll be discussing with Heidi tomorrow. Right now, we're kicking off the second of a four-part mini-series, and we're with Alvira Hasan and Bill Moss, as well as Charlotte Mbou. Welcome, Charlotte. And I believe you're going to take it from here with the questions. So we'll be looking at your questions first. I want to acknowledge a few of the people who are joining us. So Samuel from Liberia, welcome to you. You've just joined us on LinkedIn. Dr. Pierre-Hubert Ngoy Kamona from Lumumbashi in the Democratic Republic of Congo. Brima Barrow from the Gambia. Jyoti Lande from India. And of course, our very own Tanushri Mandal. Charlotte, over to you.
Thank you very much, Reda, and greetings to everyone that is joining us for this day 2 of this mini-series. So I've just turned towards Bill for my first question of today. So Bill, what are the essential components of a serosurvey?
Yes, thank you, Charlotte. And what we're going to be talking about in this part 2 are what we call community-based serosurveys. This is where we go into the community, often to people's houses, although it could be at a central location, and conduct a serosurvey. So there are really 3 essential phases in a serosurvey. There's the data and specimen collection, there's the laboratory assay, and then there's the analysis and interpretation. And we're going to focus today at a very high level on the data and specimen collection. So the components here in terms of thinking about how to conduct a community-based serosurvey, the first thing is obviously to define the serosurvey objectives. This can be, what question do you want to answer? As Andrea Carson and I talked about in part 1, there are a number of uses or purposes of serosurveys. So you have to be very clear about what your research question is. Is it to estimate seroprevalence in certain age groups or geographic locations? Is it to classify a population? Do they have high, medium, low levels of seroprevalence. We can compare seroprevalence estimates across different subgroups. Say, for example, something I've done a lot, HIV-infected children and HIV-uninfected children. And if you do serial cross-sectional serosurveys, you can actually monitor changes over time. So the first thing is defining the research objectives. The second is identifying the target population, and that's driven by what the research question is. Third, we need to determine what our study design is, how we're going to actually do the sampling, and we can talk more about that. A fourth consideration or component is the specimen type. Do you want to use liquid plasma or dried blood spots or oral fluid? One has to choose the type of assay that they're going to do with the laboratory test to actually measure the seroprevalence. And one also needs a very comprehensive data management system to manage the data that are collected from the study participants and the laboratory assays, and be able to combine them for the analysis and interpretation.
Thank you very much, Bill. So, Alvira, this question is for you. What study designs can be used to conduct a serosurvey?
Thank you, Charlotte. So that's a really good question of what the different study designs are. There's various different ways you could categorize them, but one nice way to think about this is, study designs that use existing specimens that have already been collected for other purposes. So this includes residual specimens, or those that have been left over that are available at a biorepository from other surveys, studies, and surveillance systems. You could also have leftover clinical specimens at a hospital site or at a lab. That's one type, and we'll be getting into that in some of the later sessions. But for today's session, for community-based surveys, it's usually in line the designs that collect new specimens from survey participants. So this could be a standalone serosurvey that you do from scratch, or subgroups are also able to nest a serosurvey within a larger survey that is already being conducted for some other purpose, like a demographic health survey or a mixed survey.
Okay, great. How should the target population be selected, Bill?
Yeah, so as we said earlier, the target population is really going to be driven by what the serosurvey objectives are, what the research questions are. But broadly, there are two main considerations in thinking about the target population. One is, what are the demographic characteristics of the population of interest? Do I want to know the seroprevalence in a specific age group? For example, the age that was reached by a measles and rubella SIA or mass vaccination campaign. Do I have interest in a particular gender? Do I want to know more about a seroprevalence in women? So, for example, if one's interested in rubella seroprevalence and the risk of congenital rubella syndrome, one might particularly target women of childbearing age. One might also be interested in urban and rural differences. So there are a set of demographic factors that really help drive in part the target population. The second big question is the spatial scale that one is trying to estimate the seroprevalence for. Is one interested in district level seroprevalence estimates, provincial level estimates, national estimates? That's going to also help determine what the target population is. So kind of in summary, one has to consider the demographics that are needed, the demographic characteristics of the target population to help address the specific research question, and then the spatial scale, the geographic scale on which one wants to have an estimate.
Okay. Alvira, who is potentially missed in a serosurvey, and why does that matter?
That's a great question, Charlotte. So I would say there may be different categories of populations you could miss in a survey. Some examples include hard to reach populations or hard to access populations that live in very remote locations, like in a rural area, or migrant groups, especially in India, who typically move from urban to rural areas seasonally. We also faced a lot of unavailability issues, especially in urban areas, where you find a lot of locked households where families are away at work for very long hours. So we cannot get to speak to them and talk to them and get them into the survey. And of course, there are refusals. You get to the individual, you get to find the house, but they refuse to participate. But what matters is the why does it matter question. So while every survey, as you know, will have refusals and unavailability, and that is something that we accept in the study design, but it becomes a problem when you're systematically missing a certain group of people, because that can introduce selection bias. And an example of this could be like if you're doing a serosurvey and you're trying to evaluate the impact of a vaccination campaign and trying to check what the population immunity was. If there's a hard to reach group of families who are missed in the campaign, and then we miss them again in the survey, then the result we're getting out of the serosurvey are not representative, and maybe you're overestimating the seroprevalence, or the results may look better than they really are. So it really depends on who you're missing and how much.
All right, thank you very much, Alvira. My next question is addressed to you, Bill. Say, how should a specimen type be selected? What are the pros and the cons of different specimen types? You may want to add that.
Yes, this is really important, Charlotte, because collection of specimens is really obviously critical to any type of serosurvey. One needs a biological specimen in order to measure the IgG antibodies, or it could be other types of antibodies or even antigens in a seroprevalence survey. So one has to consider, how the specimen is collected. We can collect blood specimens through venous blood, through venipuncture. We can collect blood through capillary methods. We're using like a finger prick or a heel prick in a very young infant. We can also do serosurveys using oral fluid. There are IgG antibodies that are in cervicular fluid, and that's another way of collecting a specimen. We can also have different types of specimens, such as serum, in which the blood is allowed to clot, and one would need to centrifuge that down, and one can measure antibodies in serum. One can use anticoagulated blood and separate out the plasma. And a very common specimen type for serosurveys are dried blood spots. This is because of the ease in which these can be stored. They can be stored at room temperature. It's easy to transport them, and they can be much easier to handle in more remote communities than say a liquid blood specimen. So one has to consider also the type of assay that's being used, and whether, for example, it has been validated for dried blood spots. In our experience, we sometimes get lower results when using dried blood spot, a lower measure of antibody level when using a dried blood spot compared to a liquid blood. So one has to make sure that the assay really has been validated for dried blood spot, and one needs a standardized protocol for eluting the serum off of the dried blood spot. Community acceptability is another very important consideration. We and many others have found that using finger prick blood collection is much more acceptable in many communities, although not all communities, than venous blood sample collection. One has to consider the volume of blood that needs to be collected. There are certain limitations, obviously, on how much blood one can collect through a finger prick. So there are a number of different considerations in terms of the type of assay that one is using, the community acceptability, the logistics about transporting and storing specimens that really drive the selection of specimen type.
All right, thank you very much for that answer, Bill. Now, my last question for this Q&A is addressed to you, Alvira. Say, are there resources or guidelines that are available to help guide those planning community-based serosurveys?
Thanks, Charlotte. So I would like to point to a resource that we've been working on, the serosurveytools.org, that we mentioned in the prior session. So there we've obviously compiled useful resources to help you plan and initiate surveys. But it would be important to mention some of the WHO resources that we use to design and plan surveys. And these include the WHO Vaccination Coverage Cluster Survey Reference Manual, which I think some in this network might be very familiar with. While these are mainly help you design vaccination coverage surveys, there's a lot of overlap between serosurveys and vaccination coverage surveys. And then also we have the WHO Measles Rubella Serosurvey guidelines that look more into the serology side of things. So yes, you can see that on the screen there.
All right, thank you very much, Alvira. And Bill, now I'll turn towards Reda, see if there are any questions, additional questions that are coming up on our various platforms. Over to you, Reda.
Thanks very much, Charlotte. So there are many folks introducing themselves, and there are a couple of questions. So remember, we are looking at the comments. That is where you can ask questions, whether you're on Facebook, LinkedIn, wherever you may be. So let's see. We have Iyad Abdelgadir, who asks, any issues regarding non-specific cross-reaction of IgG tests? So that is question one. And then Dr. Tanushri Mandal wants to know, is venous blood collection very popular in serosurveys as people are quite apprehensive? Oh, and she says, Bill, you answered her question. All right.
Yeah.
Yeah, so maybe Reda, I can take the first question. There are situations in which cross-reactivity can be an issue. We don't see that in measles or rubella serosurveys, for example. Those are monotypic viruses. There's just a single serotype. But for other viruses, there can be cross-reactivity. So, for example, there can be some cross-reactivity between viruses such as dengue virus and Zika virus. There can be cross-react, and particularly for dengue viruses, because there are 4 serotypes. So there are certain viruses where cross-reactivity can be a problem, but other viruses for which that's not a problem at all.
Great, thank you, Bill. I want to turn to Charlotte to ask you, Charlotte, what are your thoughts having listened to the second Q&A, second in a 4-part series? Any additional questions that you might have as an immunization professional?
Okay, thank you very much, Reda. And I've really had quite a it's been a learning experience for me getting to actually know how, what is around organizing a community-based serosurvey. Now, the questions that have been going through my mind is what's the profile of the people that could be involved in organizing a serosurvey? Is it just anybody, or, you need some specific skills to be able to take part? And Bill, you could start. Alvira.
Yeah. Yes, thanks, Charlotte. Serosurveys are complex endeavors. There's no doubt. We don't want to, underestimate the complexity of them. And so they require, actually a team. It's very important to have a team. There's individual skills in the field and data and specimen collection side. So designing the sampling strategy is really important in order to obtain a representative sample so that you can infer from your serosurvey results to the more general population. Some experience and expertise in designing questionnaires is very helpful so that you collect accurate data on the study participants. Experience and expertise in blood collection and storage and transport is very important. So there's a set of skills on this team around the field and data collection. the specimen and data collection. Then you need a team with expertise or experience in running the assays. Often these are enzyme-linked immunoassays, ELISAs, but there are other types of assays that can be used for serosurveys, and more, hopefully we'll see the use of multiplex bead arrays where we can measure antibodies to multiple different pathogens simultaneously. And then we also need expertise or people on the team with some statistical expertise who can help with the analyses and interpretation of the results. So this is a collaborative team effort with multiple different types of expertise and experience. But these have also been done around the world, and so there's certainly it's not certainly an insurmountable problem, but I also want to emphasize that it does require this type of multidisciplinary team in order to have an accurate serosurvey.
Thank you, Bill. That's it for this part 2 of 4 parts. Join us at the same time tomorrow on the same platform, whether you were watching this on LinkedIn, YouTube, Facebook, Twitter. You will find this must-see television for immunization professionals interested in serosurveys. You can also find on the Geneva Learning Foundation's webpage the workshop we just did with Dr. Anne Lindstrom from the World Health Organization, focusing on, really for immunization staff in countries, what does the availability of COVID-19 vaccines mean for you, and what is likely to change? What are you going to have to adapt to and learn in order to contribute to your country's introduction of COVID-19 vaccines? Tomorrow we are having this workshop on vaccine confidence with Professor Heidi Larson. So these are activities of the COVID-19 Scholar Peer Hub. And last but not least, I'm super pleased to announce that in the January, the 26th to the 28th of January, we'll be holding the Teach to Reach conference. Teach to Reach is a long-time program to improve immunization training. This COVID-19 vaccine introduction is pretty obviously going to be probably the ultimate Teach to Reach challenge, and it'll be the key topic at this conference in January. Look for the registration information to make sure you get your ticket early to join this conference. Now, go to serosurveytools.org to learn more about serosurveys. This is only, I think we're the first to announce and share the information about the availability of this new tool developed by the International Vaccine Access Center. And join us tomorrow, because this is a 4-part series. So Thursday and Friday, you'll find again 15 minutes, maybe a little more if there are good questions. Thank you, Jyoti Lande, who thanks speakers and the TGLF team. Thank you for joining us. Manoj Kumar, thank you for the very useful info. Thanks back to you. And I think that's it for today. Thank you.